Welcome to the pIBD Digest, the podcast where we break down the nuts and bolts of inflammatory bowel disease, especially in children. From Crohn's disease to ulcerative colitis, we bring you expert insights and lively discussions to help make sense of it all.
Myself, Dr. Chris Bakewell, and my colleague, Dr. Tracy Coelho, will be your co-hosts on this journey. In each episode, we speak with an expert guest to better understand paediatric inflammatory bowel disease, support families, and keep healthcare providers informed about the latest developments. Just a reminder, the opinions shared here are those of our guests and hosts, and are therefore for educational purposes only. This is not a substitute for medical advice.
As we record this podcast, we sincerely hope for peace around the world. Our thoughts are with everyone across the globe affected by the conflict. So, as we are releasing today's episode, Artemis 2 has just splashed down in the Pacific after a historic, groundbreaking lap around the moon, which is very, very exciting.
Yeah, hi Tracy. Extremely exciting, but as humble podcasters devoted to paediatric IBD, I say we stay firmly grounded within our own orbit of paediatric gastroenterology.
That's fair, although given the complexity of IBD, I would argue we are not that far off rocket science. Anyway, before I drift off into space again, back to Earth, mission control, pediatric IBD. So, what's on the menu today?
Right, yeah, so as many of our listeners will know, and maybe even some remember attending, we had our annual BSPGHAN conference in Leeds at the end of last month. And as with all national conferences, the real challenge is, of course, choosing between sessions to go to or quickly catching up with colleagues, someone you haven't seen for maybe the last 12 months. For colleagues who couldn't make it to Leeds, and for our international listeners, as well as for anyone who got more distracted by the pastries than the plenary sessions, we've hijacked the speakers from the paediatric IBD sessions at the BSPGHAN conference, and we brought them straight into the podcast studio.
Chris, as you may recall, at the conference I was far more involved in the hijacking portion, or rather strategical acquisition, than the networking itself, all in the interest of public service. So, today we are asking our guests to kindly regurgitate the key messages of their IBD talks from the conference.
And that's purely educational regurgitation, of course. So in today's episode, as we said, we're going to be joined by these paediatric IBD colleagues. And first up, we've got Dr. Chanchlani. He's going to help us to navigate the latest ECCO ESPGHAN IBD guidelines. He'll give us the updates, the nuances, and the bits that everyone claims they've read cover to cover. Then we'll also have Dr. Rebecca Little. She's a consultant paediatric gastroenterologist from Glasgow and also happens to have won the best oral presentation at BSPGHAN. She'll talk us through paediatric IBD standards, talking about what good looks like and how close we're actually getting to it in practice. Then on our next episode, we're going to continue that BSPGHAN debrief by inviting our adult IBD colleagues who spoke at the conference.
Right, significantly closer to home than the moon, no countdown, no launch sequence. Let's jump in.
So today's episode is inspired by our recent trip to the BSPGHAN annual conference in Leeds, where we heard some fantastic talks pushing forward how we think about IBD care in children. We thought we'd invite some of these key speakers to talk to us today and hear some of their wisdom. And we're really pleased to be joined by Dr. Chanchlani, a senior paediatric GI registrar at Birmingham Children's Hospital, who delivered a really engaging session on the clinical scenarios in paediatric IBD and how we actually apply guidance from the European Crohn's and Colitis Organisation, ESPGHAN, to our day-to-day practice. Neil, welcome to the podcast.
Thank you very much. Long-time listener, first-time attending.
That's very kind and we are honored. Neil, it's fabulous to have you here today. For anyone who doesn't know him, Dr. Chanchlani is a big name in the IBD world with a CV that strongly suggests sleep is more of a theoretical concept than a daily necessity. The fact that he's post-nights and still upright, coherent, and speaking to us is frankly heroic. Neil is also famous for the PANS-E study with Professor Tariq Ahmed and others, a landmark personalizing anti-TNF therapy study in Crohn's disease, and possibly the only time we can say PANS repeatedly in a scientific setting and still sound credible. Today, however, Neil will be giving PANS-E a well-deserved rest and move on to something different. Neil, go on then, give us an elevator pitch of your BSPGHAN IBD talk.
Thank you again for having me both, and thank you to the organising committee of the BSPGHAN conference for inviting myself and Professor Richard Russell to deliver this talk. This was a talk that reflects the updated ECCO ESPGHAN guidelines for both Crohn's disease and ulcerative colitis, which were recently published last year for ulcerative colitis and are due to be published later this year for Crohn's disease. The guidelines are a fantastic collaborative initiative of about 27 to 30 members across Europe, mostly of whom are pediatric gastroenterologists, but also representatives from ECCO, pediatric surgeons and dietitians, and as well as colleagues in North America and in Israel as well. For the Crohn's disease guidelines, there was 27 of us working on 9 separate working groups. And we just updated the 2021 guidelines and its predecessor, the 2014 guidelines, into reflecting the latest evidence-based recommendations for the care of children with Crohn's disease. And I was responsible for working group 9, along with 3 other colleagues, looking at maintenance therapy for infliximab and adalimumab, but also had multiple input across 3 voting rounds to finalize the draft statements. So the final guideline contains 42 statements, and it's worth saying that they're currently in press, or rather currently in peer review, and are waiting to be published. So what I'm going to give a flavor of today is really where the guidelines are likely to be headed, rather than a confirmation of what they're going to look like formally. For ulcerative colitis, there was 2 sets of guidelines published last year, one reflecting ambulatory care for ulcerative colitis and the second reflecting acute severe ulcerative colitis.
That's brilliant. Thanks, Neil. So do you want to give us a flavour of the content of that talk then, just for those who weren't able to attend the conference?
Yes, of course. Thank you. So we really highlighted different cases in which the recommendations could be applied, in particular highlighting new or updated recommendations that may reflect a change in practice than what may have been considered standard practice previously. For ulcerative colitis, the key take-home messages we wanted to reflect are to follow the updated algorithm, and in particular using the pediatric ulcerative colitis activity index score upfront at presentation to make sure you remember that PUCI score of greater than 65 is consistent with acute severe ulcerative colitis, and to use that calculation or that tool frequently throughout the patient's admission and to guide how they're getting on it and your response to any interventions that you put through. Importantly, although toxic megacolon is rare in some settings, in the UK we might see it 3 to 4 times a year, you'd be very caught out if you miss it. And so there was substantial reinforcement to look out for toxic megacolon and also what those signs and symptoms might be, both clinically and radiologically. Reflecting a key change in the ulcerative colitis guideline updates was in whom to consider thromboprophylaxis and in what circumstances too. And the key message there is to think broader than we might have before and to consider dual therapy, not only with TED stockings, but also low molecular weight heparin if your patient fits the bill. And to consider second-line therapy early on and really about planning that process. If you have someone unwell who looks like they're not responding to conventional first-line therapy, thinking about second-line therapy, almost always high-dose infliximab, and when to consider switching that preparation from intravenous to subcutaneous, if that's available for you, which of course it isn't for everyone. For Crohn's disease, the key take-home message is that the guideline is likely to head towards is to treat patients at high-risk disease, so that's most of our Crohn's disease patients, intensively, and that is usually with the use of anti-TNF therapy up front. But we made a key recommendation here to bridge that time or that potential delay with adequate nutrition, either in the form of exclusive enteral nutrition or partial enteral nutrition, to plan your therapeutic drug monitoring strategy early, but also proactively if you have access to quick turnaround of results, and to consider advanced therapies early on as well. We're at a lucky stage now, and probably one that is unique compared to where we've been previously, but hopefully not too unique going forward, where we have increased access to advanced therapies in some settings, and with the recent licensing of ustekinumab last year across Europe. But not only that, also when you might consider alternative advanced therapies such as upadacitinib or risankizumab.
That's brilliant. Now, for our non-medical listeners, PUCAI, spelled PUCAI, stands for the Pediatric Ulcerative Colitis Activity Index. It's a clinical scoring tool which we use particularly for children who are admitted to the ward to assess how active their ulcerative colitis is and how they are responding to treatment. The score guides our decisions on whether we need to escalate treatment, continue with the current plan, or make other adjustments. So, coming back to your talk, Neil, you have just mentioned about VTE prophylaxis. Could you explain to our non-medical listeners what this means and why it is important?
Yeah, sure. So VTE is short or an abbreviation for venous thromboembolism, and it can occur in any patient who has a high inflammatory burden, or what we call a hypercoagulable state, which just means they have a tendency for their blood to clot more than other patients. When you have a high inflammatory burden or lots of inflammation, like in someone who presents acutely with ulcerative colitis, you are at increased risk of your blood clotting and having a clot somewhere in the venous system. Now, we used to think of this as primarily an adult problem or an older child or adolescent problem. And I think that line of thinking has advanced, particularly in the new guideline for acute severe colitis. The updated guidelines now ask clinicians to consider both medical and non-medical therapies or treatments for all patients who present with acute severe colitis. And the aim of those treatments would be to reduce the risk of that clot happening in the first place. And many of these things, patients with acute severe colitis are not necessarily able to do when they're so unwell on day 1, day 2 of presentation to hospital, having probably already been in bed for the previous 1 to 2 weeks. So those are kind of common things like mobilizing well, drinking well or hydrating well, kind of getting out of bed, walking around, and making sure that you have good nutrition and food intake. Now, those aren't obvious priorities for someone who feels really rubbish and who's in a hospital bed. So it's now up to the clinicians to make some of that therapy or to guide some of that for patients. So what the new guidelines advance us on or have taken us forward on is in whom to consider giving medicine to and how best to deliver that. So they firstly give you a really nice decision algorithm on what to do. So even if you don't have time to read it, at 3 a.m, there's a figure there that tells you exactly how to walk it through. And that separates patients into inpatients and outpatients. Now, people who are being managed as an outpatient are less likely to get these clots anyways, because they're walking around, they're moving, and they're probably almost certainly less sick than those who are admitted as an inpatient. And again, the stratification or determining risk is based on your PUCAI score, which you nicely explained, Tracy. So that is, if you have a very high PUCAI score, that's probably more reflective of a high inflammatory burden. If you have a lower PUCAI score, you're likely to have a lower inflammatory burden, and therefore your decision of whether you might give medication to treat a venous thromboembolism changes. Now, what's also emphasized in the new guideline is risk factors that might put you at an increased risk of developing a clot. So that could be if you're on certain medications, if you've had recent surgery, if you have any lines in, so like a central line or any pieces of plastic, like a catheter that you happen to have. If you're a larger weight or higher obesity, that also puts you at increased risk. Or if you're an older child who may smoke, again, increased risk. So it gives you that mapping and that framework of in whom to start. And we've moved away from just considering conservative measures like gentle encouragement and good fluids to actually giving a medicine called low molecular weight heparin. And what that is a injection into your tummy that releases medicine to stop that clot from forming. Whereas the older guideline just focused on those conservative measures in addition to stockings that help increase venous return back to the heart. There's now a much larger emphasis on giving low molecular weight heparin, particularly to those who are considered to be at the highest risk of developing it, so inflammation and inflammatory burden. And that data really came from a registry study called the pIBD SETQ Safety Registry, and that was a Europe-wide registry. And what that found was that cerebral venous sinus thrombosis, so that is a clot in the brain, unfortunately, was one of the most frequently reported types of clots that can happen. And what it also found was that where our previous thinking of these clots tending to happen in those who are older, so maybe the 12 to 14-year-old mark, and adults, the study actually reported a higher incidence of these clots happening in prepubescent children, so that is less than 12 to 14 years of age, and in patients potentially with no risk factors at all beyond having ulcerative colitis and a new diagnosis. So it really reset our way of thinking of in whom to give this medicine to and whom to treat early with.
Neil, your explanation about the risk of VTE in IBD was absolutely par excellence. Honestly, the best I've heard.
Thank you.
You're welcome. Now, while we are on this topic of VTE, when would you recommend starting prophylaxis treatment?
So you can start on the first day that they come to you, really, whether that's an outpatient clinic or when they're admitted on the ward and you think they need it. The chances are they've probably had a high inflammatory burden prior to that point. That is worth getting on top of on day one.
So I guess in practical terms, start VTE prophylaxis early during the admission. And although the guidelines don't really pin down the exact duration, but a sensible approach, I would think, would be to keep it going while the patient is acutely unwell and not moving much. And once they are feeling better, up and about, probably that's the point where we decide to stop.
I think the key is the starting, isn't it? It's the once you think about it, you start it early, and you don't underestimate the inflammatory burden and the thromboembolic risk, because clearly there is one, and clearly it's not just older children, it's younger children as well.
Yeah.
Thanks, Neil. I was going to ask you maybe a slightly harder question and a bit more existential. So firstly, how long did it take to form these new guidelines? What was in terms of the length of time from when you first sat down as part of the working group to when they first went to peer review?
So it's been a long labor of love, and actually it's been a real personal journey as someone who's not been previously involved with guidelines to get involved and really find out about that process. It started 2 years ago is when I first applied, and when we met shortly after that in June 2024, and it's taken about 2 years to go through at least 4 to 5 revised drafts, including practice pointers, clinical recommendations, appraisal of the entire evidence base over the last 4 years, 3 rounds of voting. We've only just finalized the statements and the final draft nearing peer review back in January of this year. So it's not gone to review just yet even. And I think that is quite typical for a clinical practice guideline of this nature that encompasses quite a lot of content, but also reflects multiple specialties and subspecialties across pediatrics, adults, radiology, and surgical literature.
Thanks. Because my question was going to be, sometimes these processes are very long and they can almost be outdated by the time they're published. Is that at all a frustrating process, how long it takes to get them through various revisions? Admittedly, not much changes sometimes within medicine, but there can also be times when things change quite a lot. I'm thinking of the adult, the BSG IBD guideline that was just published, which is this enormous document, and you feel like the process of going through and revising that might then take a further 6 years, and then you're sort of in this continuous cycle of creating a guideline. But it was just interesting to know your perspective on that.
Yeah, absolutely. And I think that's a really good consideration for when you do look at a guideline that's newly published. What was the time lag on this? And For pediatrics, that's probably slightly less a concern for us compared to adult literature or even other specialties, because of the nature of how often new original data gets published to inform the guidelines. So although 4 years might seem like a substantial time period, there wasn't a great synthesis involved that had changed between the previous guidelines for some of the sections. But part of that beast is totally acknowledging the guideline, the wider teams of the guideline who coordinate the guideline, and the multiple working groups that engage very well with their specific part. We are updating the search up until it goes out to peer review even. So from that time point, we make sure we're up to date. But after that, it becomes harder and harder to update.
That's amazing. Neil, as you mentioned earlier, that these guidelines have been your long labor of love. But we have been seeing the fruits of your labor popping up everywhere. So be honest, how do you juggle the balance between delivering babies through academic midwifery and your clinical job?
I think whilst this project is still not near the end, this is my focus from a clinical guideline perspective. But it's always useful having other projects on board that you're working on. I dropped my full-time clinical work in order to accommodate other projects, including this one, as well as my editorial work. So that makes me in a position to work on these things, not totally at home and out of hours.
Hey, look, Neil, I think on behalf of Tracy and I, we congratulate you on your work. It's clearly an excellent thing to have done. And I think we're really excited to see the outcome of it when it does get published. We've had the UC guideline, we're waiting for the Crohn's guideline. And I think this forms a really important part of our clinical work. And, I'm sure it will be accessed by many, many people. So congratulations.
Thank you very much.
Absolutely. Great work. Of course, I can't let you off just yet. I have one more question, please. Now, in your talk, you have clearly highlighted the importance of proactive therapeutic drug monitoring, TDM, over reactive TDM. However, the British Society of Gastroenterology Guidelines 2025 seem to place less emphasis on proactive TDM. So how do you interpret the difference?
Yeah, I think the guideline committee was careful on advancing the clinical recommendations in relation to the scenarios in which you would utilize proactive and reactive therapeutic drug monitoring. And I think the rationale for that, particularly for children, is almost why wouldn't you? It's not a particularly expensive tool. It can greatly inform your next stage in your practice. And I think we do have much more clarity on what we're aiming for when we do receive the results of those tests. So in the guideline, we'd recommended a few key clinical scenarios for proactive therapeutic drug monitoring. That is, for infliximab, that is before your third infusion, and for adalimumab, it's before your third injection, before any de-escalation of any therapy, but in particular, the withdrawal of an immunomodulator. And for many children and young people, that might be after being on an immunomodulator for 6 to 12 months, or when considering therapeutic de-escalation kind of at the 1.5 to 2 year mark. And we recommended to apply reactive therapeutic drug monitoring in the setting of any sort of loss of response, whether that be clinical, biomarker, or endoscopic loss of response, or any incomplete response after an intervention. And I think why we've done that and why we've stipulated that so carefully is because we need to optimize the use of our advanced therapies as much as possible and really think about durability. We don't have as many options as our adult colleagues do for their populations. So what we can't do is risk losing an intervention because we did not think or act hard enough on how to make it better. So what's new in this guideline compared to the previous guideline is also clarification of what minimum target concentrations to aim for at the end of the induction period, which would be 15 for infliximab. But we've increased that for adalimumab from 7.5 to 14 for the end of induction. And that was based on lots of retrospective data, as well as the Palliates randomized control trial, which helped guide us. And for maintenance therapy, for anti-TNFs, we'd also increase the minimum lower boundary trough target for infliximab from 5 to 8, and for adalimumab increasing from 7.5 to 10. And again, that was in part based on, I know you wanted to avoid talking about it, the PANTS extension study, but also lots of other retrospective pediatric work, which has informed us that trough targets lead to better outcomes, not only in the first year, but all the way out to 3 years. Why the VSG didn't emphasize when to perform therapeutic drug monitoring is possibly because there has been recent data in the last 2 or 3 years in the form of systematic reviews and meta-analyses, which have not shown perhaps the anticipated benefit of proactive over reactive therapeutic drug monitoring. That was really seen in the trials of adult data, and in particular when you also look at immune-mediated inflammatory disorders that combine inflammatory bowel disease along with other conditions such as rheumatoid arthritis or dermatological conditions. And actually, when you reanalyze those prospective data with retrospective data, and there was a really nice review published in systematic review published in AP&T about this, you can find a potential benefit. And it all comes down to what outcomes you're looking at, whether that be cost effectiveness, primary non-response, secondary loss of response, long-term remission. But for me, I think, what do I have to lose with a relatively cheap tool? If it takes you a longer time to get those results, that is a different sort of play. But for most people, getting it back within 1 to 2 weeks from many of the labs that now do this test in-house rather than ship them away to another center means that you can act on them quite quickly, and you can make a really potentially important decision for your patient.
That was brilliant. Thank you.
Good answer.
It's 5 years of living in TDM. Hopefully I can answer that now.
Well, thanks very much, Neil. We were lucky enough to see your talk in person, but to relive it a second time is very helpful. And for those that weren't there, they've clearly got a nice insight into what's coming, what's new, and picking your wisdom and understanding why things are changing. So thanks very much, and we really appreciate your time.
Thank you very much.
So I'd like to introduce our next guest to the podcast, Dr. Rebecca Little, who's a consultant paediatric gastroenterologist based in the Royal Hospital for Children in Glasgow, and notably very active and productive member of the BSPGHAN IBD working group. Rebecca has an incredibly impressive CV, and I became exhausted reading through it earlier. But very significantly, she worked in Toronto doing a fellowship between 2019 and 2022 at the Hospital for Sick Children, working with some very impressive names and expanding her research horizons on IBD PSC research topics. So welcome to the podcast, Rebecca.
Thank you very much, Chris, and thank you, Tracy. It's a pleasure to be here.
Oh no, thank you for joining.
So just before the podcast started, we were congratulating you on winning the award for Best Oral Communication at BSPGHAN 2026 in Leeds. A fantastic achievement. How do you feel?
Very shocked, I have to say. I was on call on Friday, and I was doing an emergency endoscopy and just happened to walk out of a theatre and saw a text message from our resident doctor who'd been on our Glasgow case study saying, "You won the prize." And I have to say, it was a shock, but a nice way to end a Friday. So I'm incredibly, incredibly honoured to have been the recipient.
Well, we won't embarrass you by giving you the round of applause now. You can imagine how it went. Rebecca, thanks for coming. Could you start us off by briefly explaining to our listeners what the UK IBD standards are and why they matter to paediatric IBD care?
Perfect. Yes, the IBD standards, they were published in 2019, and they define the key parameters and aspirational targets for delivering high quality healthcare to both children, young people and adults at every stage in their IBD journey. They were designed by IBD UK, which is a partnership of 16 patient and professional organisations, including BSPGHAN, and it's led by Crohn's and Colitis UK. And it's done, which is really nice, in collaboration with people living with IBD. So we get the integrated input from people with lived experience of IBD, and they will feel seen and heard within shaping care for our patients. The standards span across the design and delivery of our multidisciplinary IBD services, the journey to diagnosis, the timeways and referral pathways and protocols, what we should be doing for our newly diagnosed patients, how we manage flares, how we empower our patients, the role of surgery, which is becoming less and less now in the advanced biologic and advanced therapy era, how we manage our inpatients and the long-term care. In paediatrics, the relevance to ourselves would be that it provides a framework for how we can get it right first time for our patients when we know that significant lengthy delays in diagnosing and initiating treatment for children with suspected IBD not only results in deterioration in their physical health by the time of endoscopy, but also significant increased psychological distress from the prolonged uncertainty, as well as the embarrassing symptoms which cause them to withdraw from the things that they really enjoy, their sport, their dance classes, their time with friends. And it's a crucial time in a lot of their development. It impacts their growth, their development and their educational attainment. So the guideline, the framework and the IBD standards are designed to reduce variation in care and provide equitable access and make it less of a postcode lottery, and ensure that we get consistent, safe and personalised services across the UK. And to kind of benchmark where our services were in relation to the 2019 standards, in 2023, IBD UK distributed surveys to patients, their families, as well as our paediatric and adult IBD services across the UK. And they generated a comprehensive report of that that was published at the end of 2024. And that report had a real impact. It made the national news and provided a moment where IBD was in the spotlight for everyone to see. And it's really vital that we continue to maintain that momentum, and also within that give paediatrics the platform that it deserves. So the results of the 2023 benchmarking, along with the nested case study, were the primary focus of my presentation at this year's BSPGHAN.
Wonderful. Thanks so much. It's very, very meaningful work. And obviously you presented some really compelling data on, sadly, the widening gap between the national IBD standards and the reality of paediatric IBD services across the UK. For those that couldn't attend your talk, which sadly was also myself, could you give us a condensed outline of those key findings?
Yes, absolutely. My talk was 7 minutes, so I'll try and give you the abbreviate condensed version of that came from the State of the IBD Care report, which was over 80 pages long. And sadly, within the content of that report and our paediatric data, the responses indicate that there's a significantly reduced perception of care quality between 2019 and to now. Patients are experiencing significant delays at every stage of their interaction with the healthcare system, and this is resulting in increased ED attendances, emergency procedures and admissions. But there is a lot of good practice, and I think the work we're doing in the NHS and in our paediatric IBD services, certainly from some of the other talks that we heard on the day, and some of the other co-stars on this podcast may have alluded to, that our paediatric practice is outperforming our adult colleagues. But still, despite that, no single IBD service across the UK currently meets the standards for care, and that's across care and staffing. And very sadly, little progress has been made since 2019 on this. So the core themes across my talk looked at the patient and service overview, the workforce, and predominantly focused on the journey to diagnosis and a bit about treatment and personalised care. So I think it'd be quite pertinent to look at the extent of our services. So we currently have an estimated 6,786 children and young people living with IBD across the UK, and just under 10% of patients responded to the survey. Unsurprisingly, Crohn's disease remains the predominant phenotype at 60%, with 32% ulcerative colitis and 8% IBDU, with an average age of 12.4 years at the age of diagnosis. 26 of our tertiary PGHAN services across England, Scotland and Wales were captured within the survey, and on average each centre is diagnosing 76 children and young people with IBD as a new case per year. Our services, however, are well governed with clear, strong leadership, and nearly all centres have treatment guidelines and protocols for steroids, immunomodulators and biologics. When we looked at the workforce and the typical paediatric MDT, what it identified is that particularly across dietitians, psychologists and IBD specialist nurses and pharmacists, there are significant gaps in services across the UK, and that really needs to be a focus for investment into this vital resource. The journey to diagnosis is where the real crux of the shocking data comes in. So only 50% of patients with suspected IBD will have their initial clinic appointment within the 4-week target. And add to that, just 54% of our patients meet the targets of having their diagnostic endoscopy within 4 weeks. What's even more striking is that only 8% of patients will have their biopsy report available to their IBD clinician within the 5 working day target. And add to that the small bowel imaging. Only 16% of patients will get their complete GI top-to-toe workup with small bowel imaging within 4 weeks. Only 16%, less than 1 in 5. That said, it's not all bleak. All patients will start their treatment within 1 week of confirmed diagnosis. And what was quite interesting to me is there was a slight difference in perception when we looked at the patient and family responses compared to the clinician responses, where the wait time for commencing of treatment, patients were reporting that to be about 3 weeks, which I think really ties in with that difference in perception, where for patients, the time to starting treatment starts ticking when they get that endoscopy, whereas we view it as the time when the biopsy report comes to our inbox. They also looked at the patients who had had a flare, and 46% of patients will have had a flare within the last 12 months, and 74% will receive a response with a flare action plan within 48 hours target, which is really down to the fantastic work of our paediatric IBD nurses who man that phone line and provide that vital point of contact for concerned patients and families. But yet 1 in 4 patients are still waiting more than a week to start treatment for a flare. So in the whole, the 2023 benchmarking has identified a high proportion of our services are not meeting target. And there was subjective clinician experience, and from what we've discussed within our BSPGHAN IBD working group meetings, is that even since that time capture at 2023 to 2025, now we feel that gap has probably even more widened. And I presented a nested case study of my high performing centre of where we're at now. We've even seen year on year delays. So as a response of all of this, the IBD UK standards working group have now revised the standards, and later this year the new 2026 IBD UK standards will be published, and that's hopefully going to reflect more contemporary best practice and NHS priorities, and taking into account the rising incidence and ongoing operational delivery challenges many centres continue to face.
Rebecca, this is a huge piece of work, and well done again. Now you have given us a really clear and thoughtful synopsis of the presentation, but what I wanted to ask, were any of the findings genuinely surprising to you? And were there particular domains where we seem to be falling short, or perhaps others where we are actually performing better than expected?
Yeah, that's a great question, Tracy. I think 2 key themes came out for me in terms of surprising results. I think what really hits home to me is where you live currently matters. And the national average wait times for the first clinic appointment and endoscopy were quite surprising to me because, as I've said, I'm incredibly fortunate to work in a high-performing IBD centre where at the time of benchmarking, over 95% of our patients were getting seen their first clinic appointment within 4 weeks, thanks to our rapid access clinic system. And we had similar high performance for endoscopy. But looking at the national average and hearing the experience of other centres from the deep dives, it's very clear that there's a variation in service provision across the UK, and the wait time to diagnosis for children and young people is very much a postcode lottery. And I feel quite passionately and strongly that this inequity is unacceptable. And again, what's quite striking is that the constraints that we continue to face across the MDT, the fantastic pathology colleagues and radiology colleagues that we have who are working across the constraints of trying to manage multiple in-feeding specialties, but yet we've got such a delay in our biopsy reporting time and small bowel imaging, which would help us to escalate based on risk stratification, which patients need upfront biologics per se, but patients are waiting 3, maybe more months to get their imaging.
Thank you, Rebecca. That's really helpful. So I suppose the next logical question is this. How can we actually use these findings to improve pIBD services across the UK? And what practical steps or even system-level changes do they start to point us toward?
Yes. I think firstly, in terms of our services, I think we're really facing the perfect storm of the rising number of cases against the background of challenges and also the current financial crisis, and our services are just not able to keep pace with demand. As an IBD working group, we continue to advocate at national level for our pIBD service and to give them the platform they deserve. We definitely need urgent investment, not naive enough to think that there is an endless pot of money at the end of the rainbow. We have to advocate and perform local audit and advocate in our centres for additional funding. But I've also taken the opportunity to learn from international colleagues. So I presented this data at the International Paediatric IBD Symposium in Sorrento in October 2025 to raise awareness and learn from our colleagues across Europe, North America and all over the world about the common themes. And many of what I've mentioned today has been echoed across all of the centres. And we discussed some innovative strategies to overcome the challenges, but early diagnosis and access to a greater variety of treatments and getting treatments available within the paediatric setting sooner rather than waiting. So that decade-long wait for them to come to our door, as well as proactive drug monitoring and getting a faster turnaround on the results are pretty key. As I mentioned, sort of local audit to really drive increased investment and funding for more nurse specialists, dietitians, psychologists, and access to additional endoscopy theatre lists. One key interesting point from a practical side of things that came out through some work we've been doing in Glasgow is looking at the delay in time getting to our clinic appointment for their suspected IBD. And one of the interesting notes we had was looking at the number of patients who were referred without a calprotectin or had a Q-fit sent. So it's really a piece of education around making sure fecal calprotectin is sent and that there's a clear referral pathway for GPs to refer in to allow us to triage to rapid access and be seen pretty quickly, which is pretty much a low-cost, high-impact strategy. In terms of our treatments, again, investing in getting them seen more quickly for their flares and smarter use of our outpatients, I think really spreading who sees the patient for the most appropriate scenario in outpatients will really help to share the burden across the service. For instance, we have a really excellent pharmacist-led clinic, and we utilise that for alternating reviews of our patients who are stable on biologics, and this allows us to free up clinic slots in our IBD MDT clinic for flaring patients to be seen within a week and avoid unnecessary admissions and same-week reviews. I've kind of mentioned a bit about proactive TDM and getting the timely results in CalPros to make sure that we are recognising signs of a flare occurring and making tweaks to the medication in advance and avoiding underdosing and make sure that we're not switching prematurely through multiple biologics onto the higher costing biologics. So making what works well for us and is cost effective work for as long as we possibly can. One aspect that I think that is really positive, but I don't have the magic answer for how we improve it, is when we looked at the differences between paediatric and adult responses within the overall report. Paediatrics were outperforming adult services on a number of key factors relating to the holistic approach and personalised care of the child, with a higher proportion of children and adolescents with IBD rating their care more favourably than adults. But there were also a higher proportion of patients reporting paediatric patients, I should say, reporting they were being asked about their pain, fatigue, their extraintestinal symptoms and their mental health. So it's really key that we do seem to be getting it right in that regard, but we do know that there is a deficit in terms of our mental health support services and our ability to empower and educate families. And I think really that's one that I don't have the answer to within the NHS. One solution that we have sought within in my centre in Glasgow is we work with the charitable sector. So we've Catherine McEwen Foundation is a really fantastic charity here in Glasgow that helps us to deliver family education days and has funded psychology services for our paediatric patients, as well as running parent support masterclasses and courses to help empower our patients and their families. So I think overall, really improving our paediatric services to shape a better future has never been more crucial. And certainly we as an IBD working group will continue to do all we can to advocate at UK national level. And hopefully key NHS bodies will be in receipt of our paediatric specific report and strategic guidance soon.
Thanks so much. Should we finish? I would like to finish on a positive. I think that it can be quite demoralizing, can't it, as a clinician who works with children with inflammatory bowel disease. It really does take all of you to manage these children effectively, especially within the constraints of a time-limited, of a money-limited service. I think that, generally speaking, the outcome of some of the data is that we're doing well in paediatrics compared with adults in some respects. And I think that, in many ways, we do have excellent services. It's just dealing with that sheer volume of patients that seem to be coming our way at the moment. I was just looking back through our data for Southampton for this year, and we have 33 new IBDs in the first 3 months of the year. And those numbers are just very difficult to contend with in such time and money limited service. But what you're saying is so important, and I think that you shouldn't compromise your standards because of the constraints that you work within. But people like you winning these awards and presenting here, and I'm sure in many other places, are the right thing to do to advocate for more noise, more funding, better services.
Absolutely. And we definitely know that our voices are being heard and being heard more frequently. One of the other aspects I didn't mention was in the report, again, comparing paediatric and adult services. For sure, the jewel in our crown of our service is the strength of our MDT, and comparing the frequency of MDTs happen more frequently in paediatric services or on a weekly basis. So our patients are more likely to get quicker opinions, quicker flare action plans. And also there's a higher proportion of the core MDT present within the paediatric MDT meetings. So a higher attendance of psychology and dietitians, meaning our patients get that holistic comprehensive management plan, and nutrition is so key to not only sort of getting their disease under control, but keeping it under control. So we are doing a lot of good in paediatrics, and I think that's something we should be proud of, and we will continue to develop and hopefully grow and continue to improve.
Rebecca, that's brilliant. But one final question, and let's finish with a bit of imagination. If we handed you a magic wand and an unlimited NHS budget for paediatric IBD, what's the one change you would like to make tomorrow to close that gap? Sorry, I didn't mean to put you on the spot, but thought I'll give it a go anyway.
This is a great question. I think if there was no limits to the funding, the one thing I would invest in is probably more staffing across all aspects of the paediatric IBD multidisciplinary team, including the extended MDT and theatre staffing. Our IBD UK data demonstrates that we have good structure, design, leadership and governance of our services, but we are lacking staffing and resources to deliver optimised and timely care when needed. In honour of your love of literacy, Tracy, I'm reminded there's an African proverb that says, if you want to go fast, go alone. If you want to go far, go together. Building fully resourced MDTs with adequate staff to patient ratios and embedded psychology and dietetic services in order to facilitate our weekly IBD MDT meetings, rapid access pathways and structured transition, for example. These are really key to us being able to go further towards delivering a better future of care for our paediatric IBD patients.
Rebecca, that's such a great answer, and I love that proverb. If you want to go fast, go alone. If you want to go far, go together. Which is perfect for this podcast because we are clearly not in a rush, but we are going somewhere together eventually. Rebecca, that was great. It's been a pleasure having you on. Thank you for sharing your work and everything you're doing to help the entire GI community reset the benchmark for pediatric IBD care. And congratulations again for the best oral communication And I'm sure you'll win many more awards in the future.
Thank you very much, Tracy. You're too kind. And thank you, Chris.
Thanks, Rebecca.
Dear friends, I think that's plenty for today. Thank you for listening, and we hope you'll join us again soon for part 2 of the BSPGHAN IBD series. Take care.